Dear audience, my name is Danuta Szirmai and I'm a neurologist resident in the National Institute of Mental Health, Neurology and Neurosurgery. These are my projects that we started this academic year. My first project was about assessing the prognostic power of EEG connectivity measures in patients with disorders of consciousness. Disorders of consciousness take place on the continuum of consciousness, which stretches from coma to fully conscious state. And they are the minimally conscious state and unresponsive wakefulness syndrome. They are called prolonged disorders of consciousness if they last for more than a month. Are you sure that he will not recover? These are the really hard questions that clinicians face who are treating these patients. And it's really hard to answer since we know that almost 24% of the patients can regain consciousness eventually after 1 year of the brain injury. And this unknown prognosis is the one that leads to suboptimal treatment and the withdrawal of the treatment, which is a crucial question as well, since we know that more than 50% of these patients die because of withholding treatment for a new scenario, for example, pneumonia. So there are different prognostic markers that can be examined, but our aim was to compare the prognostic value of EEG connectivity measures and always use clinical scale, which is CRSR, the Coma Recovery Scale Revised. So our question was if EEG connectivity measures are better in predicting recovery in adult patients with prolonged disorders of consciousness than the clinical scale. We started with 6,000 articles, but we finished with only 5 eligible for full text selection. And these are the main results of our meta-analysis. So this is about the diagnostic accuracy of the prediction of recovery with the different methods. 5 articles were included in the final analysis, and all articles included at least 2 different measures. The effect measure was the area under curve, which is the discriminative capacity of a given measure. The AUC for the EEG connectivity and network metrics was 0.78, which means that it's correctly diagnosed 4 out of 5 patients. While of the clinical scale, it was 0.67, which means that it correctly diagnosed 2 out of 3 patients. I have indicated the AUC of the automated outcome prediction methods, which are basically machine learning algorithms that are comprised of connectivity measures, and you can see that it's way superior than any of the examined measures. So we arrived at a conclusion that EEG connectivity methods can be used with a good accuracy in prognostication, while the clinical scale, the CRSR score alone, should not be used for outcome prediction. And we didn't have enough data to conclude that machine learning algorithms would be better than any of the univariate markers, but they promise a good predictive ability. So we proposed to use EEG besides clinical scales in its practice. And we think that the initial state of these patients, so the first CRSR score, cannot determine their outcome. But obviously there is more research needed, and also the repetition of the already existent research is needed as well. We have submitted it to the first journal, and it's still with editor since 1 month, so we have wrote an email to them about requiring the status. The second project is basically just the widening of the scope of the first meta-analysis. And during this project, we included all kinds of EEG measures, be it qualitative or quantitative measure, and we compared them with each other and with the clinical measure, the CRSR scale. We finished the full text selection and almost the data extraction. Several emails we have written for the authors to require for the raw data. Regarding the third project, I had the opportunity to follow the Coma Science group in Liège, Belgium for 3 months. And they are conducting a huge meta-analysis of neuroimaging and neurophysiological alterations in disorders of consciousness. I was working on the neurophysiological part. And they were basically looking for diagnostic EEG biomarkers for DOC. Why? Because the misdiagnosis of disorders of consciousness can be really high, 38%. So the most challenging is the differentiation between the 2 states, minimal conscious state and unresponsive wakefulness. Their aim was basically to compare resting state EEG biomarkers in minimal conscious state, unresponsive wakefulness syndrome, and the healthy control group. We have run our first search in 2020, or they have run, sorry, in 2022 January. And since it was a long time ago, we had to rerun the search this June, and we found more 27 articles. We had some preliminary forest plots, but they will probably change, so I couldn't bring them now. Our fourth project is really interesting. It's a validation study of the Hungarian version of the coma recovery scale revised. It's a protocol plan of a diagnostic accuracy study. So we have translated this scale, the coma recovery scale revised, to Hungarian. Why? Because without using a clinical scale and only basing our opinion on clinical consensus, so aka the bedside visit, the diagnosis of these patients is 38%. And this tool is precisely differentiating the diagnosis of the patient, and it helps us to avoid false diagnosis as well. It's a behavioral scale which is easy to use, easy to learn. It's composed of 23 items and has 6 subscales in them. So our protocol, the aim of our study will be to determine the diagnostic test accuracy of the Hungarian version of the CRSR, and also to determine its inter-rater and infra-rater reliability. We are planning it to be a multicentric and prospective study. Our population is going to be adult patients with disorders of consciousness, be it acute or chronic. The index test will be the Glasgow Coma Scale, and the diagnosis of interest will be the disorder of consciousness, so minimally conscious state, unresponsive wakefulness, and coma. We hope that introducing this test will help clinicians to correctly diagnose patients with disorders of consciousness. And this is the overview of our project. And thank you very much for your attention.
Congrats on all 4. It's nice to see you back again. And regarding to the 4th project, it's now publicly available.
No, not yet. We wanted to publish it in a Hungarian journal.
And so it's only 23 items. It's like a ticking thing, right?
Yeah.
It's an inventory of questions that we don't have to measure things. Oh, okay.
Yeah.
Thanks.
I have one regarding the EEG connectivity. So what would be the ideal time for this test? I mean, from the onset of the disease or the...
Yes. Yes, I wish we could do a subgroup analysis with the time since injury and the time of the test of the EEG connectivity measure, but we didn't have enough data. So I wouldn't guess because I just don't know. It can be... So it's called chronic disorder of consciousness if 1 month passes, if it's an anoxic brain injury, but it's called chronic if it's a traumatic brain injury. So there are differences between the etiology as well. So I wouldn't guess now.